Welcome to the Beehive Doc Talks with Dr. Blair Rolnick. As a pediatrician and mother herself, Dr. Rolnick is here to answer your most pressing parenting questions and guide you through the tough spots.
So we're in the office today, and I've been seeing a lot of patients who either have asthma or don't necessarily have asthma, but are younger children with wheezing. And there was recently in 2020 an update to the Asthma Management Guidelines by the expert panel that we use to guide us on managing asthma. They put out their new report panel, or expert report panel, ERP 4. The last update was number 3, of course, which was in 2007. So it's been a while since we've had updated asthma guidelines, and I just wanted to talk briefly to parents about what those guidelines are and what kind of changes you might expect to see in your child's asthma care. So briefly, there were 2 major, practice changes for pediatricians, and those 2 changes are going to be in children under 4 with recurrent viral wheezing, meaning every time they get an upper respiratory tract infection, they also have wheezing, but between those illnesses, they do not wheeze at all. There's an updated recommendation for those kids to start a short course, 7 to 10 days, of moderate to high dose inhaled corticosteroids. And then there is another fairly large change to start something called single maintenance and reliever therapy, or SMART therapy. And we're going to talk in depth about these 2 big changes to our asthma management guidelines. First, let's just talk about a little bit about how we diagnose asthma and how we normally would treat asthma by age. So when we're thinking about asthma, we really think about asthma as a classification between intermittent, mild, moderate, and severe. And your physician will diagnose your child's asthma based on their symptoms. So how many symptoms are they having per week? How many times at night are they waking up because of coughing? Whoever has a child with asthma is aware that they cough more at night. How often are they using their inhaler? Does their asthma interfere with their normal activities like sports, play, school? And then the last component of diagnosing asthma and basing what their mild, intermediate, or severe asthma classification is by using something called PFTs, or pulmonary function tests. And those are tests that are specifically done in a pulmonologist's office or a lung doctor. And then we also take into consideration how much your child has been using systemic corticosteroids. So systemic corticosteroids are steroids that are taken by mouth because they get into your child's bloodstream and go everywhere. They're systemic, versus inhaled corticosteroids, which are puffer or inhaler-based steroids. And those steroids are really just absorbed in your child's lung as opposed to all over your child's body through the bloodstream. So let's talk about those children who are less than 4 years of age who are diagnosed with asthma. How do we manage those kids? So the first is for the mild intermittent asthmatics, or the least severe children. We usually just put them on something like albuterol, which is a short-acting beta agonist, as needed for wheezing or shortness of breath. As your child has more symptoms, or if they're less well controlled, meaning more symptoms, we step up that therapy. So in general, approaching asthma management, we treat it like a ladder, and you step up the therapy as needed. And that should be done on a reassessment. So you make intervention and you reassess your child. We would reassess your child in 4 to 6 weeks. If they're still not controlled, we step them up again. And then once we've gotten to a good level of control, we kind of hope that we get at least 3 months of good consecutive control before we consider de-escalating or scaling down the therapy. So if you think about it as a ladder, the first step on that ladder for those children who are 0 to 4 years old is just albuterol as needed. The next step is adding a low-dose inhaled corticosteroid plus albuterol as needed. The next step would be a medium-dose inhaled corticosteroid plus albuterol as needed. The 4th step would be daily medium-dose inhaled corticosteroid with a long-acting beta agonist and a short-acting beta agonist like albuterol is needed. The 5th step is going to be, again, to increase the dose of the inhaled corticosteroid to a high-dose inhaled corticosteroid, long-acting beta agonist, and albuterol is needed. And the 6th dose is high-dose inhaled corticosteroid with a long-acting beta agonist, plus those steroids by mouth, plus albuterol is needed. And why do we step up and step down this therapy, and what's all the concern with the steroids versus oral steroids versus inhaled corticosteroids. So what we really want to do are two things for asthma patients. We want to A, limit the number of exacerbations that they have, and B, particularly for children, we want to limit the exposure to steroids. When we're thinking about steroids, we're more concerned about systemic or oral steroids than we are about inhaled corticosteroids. And the reason for that is that systemic or steroids that we take by mouth have more side effects, like effects on age, risk for obesity, diet, weight, than inhaled corticosteroids, because those inhaled corticosteroids are really just getting absorbed into the lungs as opposed to into the whole bloodstream. So let's now talk about those children who are less than 4 years of age. They don't really have asthma. They just wheeze every time they get a cold, but they don't wheeze at all in between illnesses. So the new recommendation from the expert report panel for the ERP4 is for those children to have a short course of moderate to high dose inhaled corticosteroids for 7 to 10 days. And the reason that they made this recommendation is because they found using this strategy resulted in 1/3 of the risk of using oral steroids. So overall, the children that we have this 3 episodes of wheezing with viral illness, if they were started on moderate to high dose corticosteroids only during their respiratory tract infections, they had less exposure by 1/3 to oral steroids. So that's actually pretty amazing and a pretty great new finding. For children who have already had a diagnosis of asthma, this doesn't really apply to them. So in the past, when children already had asthma, we used to sometimes increase the dose of inhaled corticosteroids during the flare or exacerbation. That's also no longer recommended. So based on the new recommendations, if the child already has asthma, kind of that step ladder we went up in the beginning, if your child already has asthma and they are having an exacerbation, the best thing to do is to increase their inhaled corticosteroid for 3 months. So you're just increasing their maintenance therapy for 3 months as opposed to just in the duration of that exacerbation. And again, why do they recommend that? Because the recommendations found that when we approached asthma using this strategy, there was less use of an oral steroids, which is really one of the major risk factors we're trying to avoid. So one of the big major changes to recommendations that came out of the ERP4 is using something called SMART therapy, which means single maintenance and reliever therapy. So let's talk a little bit about what inhalers are out there and how they were being used prior to this expert panel recommendation. So before this, there were two different types of inhalers, the rescue inhaler and the controller inhaler. Your rescue inhaler would often be a short-acting beta agonist, something like albuterol or Provera. And your controller inhaler would often be either just an inhaled corticosteroid on its own or an inhaled corticosteroid plus a long-acting beta agonist. So now the new recommendation that's coming out is using, again, something called the single maintenance and reliever therapy. So that means using one inhaler for both rescue and control. And this inhaler combination is going to be an inhaled corticosteroid plus something called formoterol, which is a long-acting beta agonist. And the reason this inhaler was chosen is because this type of albuterol has a very rapid onset of action. And the 2 brand names that are available in the US of this type of inhaler are going to be Dulera or Symbicort. So why the change in this recommendation? Basically what they found was using this combination inhaler for both rescue and control resulted in children A, having better control and less asthma exacerbations, and B, that they had less use of oral steroids. So that's where this big change came from, and that you might see a big practice change in management in your child's asthma management, if your child is greater than 4 years of age and has moderate to severe asthma. So let's now go through what the new recommendations for management of children who are greater than 4 years old, so 5, generally to 11, and how we're going to manage their asthma and how it's different than it was before. So before, again, your child would probably have a controller inhaler like a low-dose inhaled corticosteroid or a combination steroid and short-acting or long-acting beta agonist, and their rescue inhaler would be their short-acting beta agonist like albuterol. Now what the recommendations are, so if your child is greater than 4 years old and they have intermittent asthma, it's not going to change at all. They're still just going to use that short-acting beta agonist like albuterol as needed for wheezing or shortness of breath. If your child is a moderate asthmatic, it's also not going to change. So they're still also going to use a low-dose inhaled corticosteroid as their controller every day. And then for rescue, they're going to use the short-acting beta agonist albuterol. Now, this is where you're going to see a change. So in step 3, if your child is a moderate to severe asthmatic, instead, the recommendation is to both daily and as needed for rescues, use a low-dose combination inhaler, which is a low-dose corticosteroid plus that long-acting beta agonist formoterol specifically. And then as your child needs to be escalated up that ladder, they're still going to use the same type of inhaler, but the dose of inhaled corticosteroid is going to change. So instead of using low dose, we're going to go to medium dose and then high dose. And then lastly, that high dose combination inhaler plus oral steroids. And then on top of that, albuterol as needed. In this age range, the 5 to 11-year-olds, we are going to reassess your child every 2 to 6 weeks to see if we need to continue to step up that therapy. And then the same thing for stepping down as in the less than 5-year-olds, we're looking for 3 months of good control with whatever step on the ladder we are before we start to de-escalate therapy. So what happens when your child turns 12? Then how does their management change? Basically, for the mild intermittent asthmatics, it's always the same albuterol as needed. And same for the mild and intermittent. The severe and moderate asthmatics, it's going to change a little bit in that they are still going to use that SMART therapy, so the same inhaler, the combination inhaler for daily and as needed, rescue and controller, but they are going to go from low, medium, high dose inhaled corticosteroids plus possible oral steroids plus PRN albuterol. Same thing, we're going to evaluate them every 2 to 6 weeks to see if they need to be stepped up that ladder. And then once we get to good control, we're going to leave them there for 3 months before we start to step down on that ladder for them. So overall, just to kind of summarize the changes and recommendations that came out of the ERP4 and what you might see in different management for your child is that if your child is less than 4 years of age and they have wheezing with every upper respiratory tract infection but no wheezing in between, they might benefit from a short course of moderate to high dose inhaled corticosteroids just during that infection. And the reason, again, for that is to try to reduce their exposure to oral steroids, which are more risky than inhaled corticosteroids. And the second big change is for those kids who are 5 and up, who have moderate to severe asthma, they might benefit from replacing their rescue inhaler and controller inhaler to using one inhaler called that SMART therapy, which is going to be the long-acting corticosteroid plus formoterol, again, the 2 brand names, Dulera and Symbicort, using that inhaler for both rescue and control. And again, the benefit that we saw for those patients was that they had less asthma exacerbations and less overall exposure to inhaled corticosteroids. And just one last thing to kind of note about this recommendation specifically for the SMART therapy or the single-use inhaler for both rescue and control is that this is really an off-label recommendation. It's not FDA approved. It has been approved in some other countries, but it has not yet been approved in the US. So I think for this expert panel to make this recommendation off-label just shows that they felt the evidence was really strong enough to make that recommendation. So I hope you've overall found that this episode is helpful if you have a child with asthma or a child who's wheezing, or you recently had a change in your child's management of their asthma. If you have any questions about your child's asthma, please reach out to your pediatrician. I'm sure they want to hear from you. And if you have any comments about this episode, please leave them below. As always, we're really happy to be there for you and hope that you enjoyed this episode.
Thank you for watching the Beehive Doc Talks with Dr. Blair Rolnick. For more episodes and her practice, visit BeKindPediatrics.com. And don't forget to subscribe for more parenting tips wherever you get your podcasts.